Neck and shoulder pain is the most diagnostically complex area in musculoskeletal practice, and it is where well-intentioned self-management most commonly fails, not because you are not trying, but because the range of possible causes is large and many of them overlap in their symptoms. The cervical spine, the shoulder complex, the brachial plexus, the thoracic outlet, the thoracic spine, and multiple referred pain pathways can all produce symptoms in the same region, and distinguishing them without a structured framework is genuinely difficult. Let me walk you through the clinical questions that help narrow the picture. The first question is whether the pain stays in the neck and shoulder region or radiates further. Pain confined to the neck, upper trapezius, and shoulder blade area without any arm radiation is the typical pattern of mechanical neck pain, facet joint irritation, or muscle overload. Pain that radiates from the neck into the shoulder, outer arm, forearm, or specific fingers, and particularly pain accompanied by numbness, tingling, or weakness in that distribution, suggests nerve root involvement at the cervical level. The distribution of the radiation tells you which level is likely involved. C5, nerve root compression typically produces outer shoulder and upper arm pain with weakness in shoulder abduction and external rotation. C6 produces thumb and index finger symptoms with biceps weakness. C7 produces middle finger symptoms with triceps and wrist extensor weakness. C8 produces ring and little finger symptoms with intrinsic hand muscle weakness. This specificity is clinically useful. If your radiating symptoms match one of these distributions, it points clearly toward a cervical cause rather than a primary shoulder problem. The second question is which movements provoke the pain. Neck extension and rotation toward the affected side that provoke arm symptoms, often called a positive Spurling's sign when done clinically, strongly suggests cervical nerve root involvement. Shoulder loading in specific directions tells a different story. Pain with resisted external rotation and overhead reaching suggests rotator cuff pathology. Pain with the crossbody reach implicates the acromioclavicular joint. Pain at the front of the shoulder with resisted forward flexion and forearm supination points to the biceps long head tendon. The thoracic spine is the third region that contributes substantially to neck and shoulder symptoms and is frequently overlooked in self-assessment frameworks. Thoracic stiffness forces the cervical spine and shoulder complex to compensate with excessive mobility, accelerating wear on structures already managing high loads. A rounded thoracic posture, the forward head position common among Malaysian desk workers, places the cervical spine in sustained extension to maintain horizontal gaze, chronically loading the posterior facet joints. The contribution of thoracic stiffness to neck and shoulder pain is not obvious from symptoms alone, but it has direct treatment implications that change how physiotherapy should be structured. Physiotherapy for cervical and shoulder conditions consistently produces better outcomes when thoracic mobility is assessed and treated alongside the primary complaint. The third question is the pattern of onset. Gradual onset over weeks to months without a clear triggering event is typical of postural load conditions, overuse tendinopathies, and degenerative changes common in Malaysian desk workers. Acute onset following a specific mechanism, a whiplash injury, a heavy overhead lift, a fall suggests a different structural trigger with different treatment priorities. The fourth question concerns associated features that change the clinical urgency. Hand weakness, dropping objects, difficulty with fine motor tasks, combined with neck and arm symptoms can indicate spinal cord compromise, which warrants prompt medical assessment. Bilateral arm symptoms, changes in walking coordination, or any bladder or bowel changes in the context of neck pain are red flags for cervical myelopathy and need same-day medical evaluation. Night pain that wakes you from sleep and does not settle with position change warrants medical evaluation before physiotherapy. For most presentations without these features, physiotherapy is the appropriate first response, and home management is reasonable for the first 2 weeks. The neck and shoulder self-assessment tool in the link in the description takes you through all of these dimensions systematically and provides clear guidance on urgency and next steps. It takes 3 minutes and is specifically designed for the Malaysian patient trying to decide whether to self-manage, book physiotherapy, or seek medical review.